and we'll give folks just a minute before we get started. Just want to confirm with Tiffany, Olivia, you guys are able to share your screen, hopefully, okay? Excellent.
I think so.
So I see folks are coming in, and I think we'll start here in just maybe 30 seconds. All right, I think we have a reasonable quorum of participants. Just say welcome and quickly turn it over to Guy, and I'm excited to see all of you today. And Guy, feel free to jump us into some opening remarks. I think we're going to go to the slide exactly. Olivia's on it, so go for it, Guy.
Great, thanks all very much. First of all, happy holidays. Happy Hanukkah for those who celebrate starting tonight. I wanted to say thank you very much for your participation. I feel like we made a lot of progress in the last several weeks. I'm excited to make more progress today. And I just really wanted to thank you again for your participation, your input, your time. I think we're learning a lot. Second, I just wanted to take a big step back and think about where we are and where we're going. So we brought up this slide. I think we've shared this slide before. For me, I think it's a really helpful framework. And we talked about these three kind of interlocking questions. One is on the care delivery, which is the what. What are the things that we should be doing differently? And we talked a lot about that in our in-person meeting a couple times ago, the what. We spent last time on the measurement. What's the definition of success, the performance measurement? Last time we talked about access, chronic condition and targeted care management, and data and infrastructure. Today, we're going to round out that measurement discussion, focusing on team-based care and health-related social needs, screenings and supports. The third piece of that interlocking chain, the what, how you measure it, and then the payment model, we're going to talk about in January in our in-person meeting on January 18th. I'm excited because I know these three things really do fit together, right? You need to first think about what you're trying to solve, how you measure it, and then how you set up the performance, the payment structure to make that all come about. And today we're hoping to round out our discussion on the measurement piece on those team-based care and HRSN screening. So looking forward to today's discussion, and I'll turn it back over to Brad or Olivia to move us forward.
Great, thank you, Guy. And I'll just make a plug that looking forward to seeing those who can make it in person. I know the commissioner is also planning on attending, and we're excited that she'll be should be there in person as well. So for everyone that can make it in person, we definitely encourage it. Understand that it's not possible for everybody. So back up to our agenda. Guy gave some brief opening remarks. Welcome. Just remind you again about the upcoming in-person meeting. And we'll go over today kind of our recap of what we discussed before and goals for what we're trying to achieve today. And we have those two remaining topics of team-based care and then health-related social needs screening and community sports, both of which we've discussed fairly extensively in prior meetings that we've had. And then we'll talk briefly about those next steps ahead of that January meeting. So next to the quick recap, and so you will recall our meeting for 2 months ago, 2 months ago at this point. That was the October 26th meeting, that in person, where we got a lot of feedback from all of you on things that primary care should be doing differently or better to improve member health and well-being. And we really created that list of 5 itemized list of 5 domains that we want to focus on, or we thought would be a great place to start. And then we did discuss whether DSS should be more prescriptive or flexible in defining what primary care should be doing for those various domains. And then our last meeting, as those who were able to attend recall, we discussed 3 of the domains that Guy mentioned: accessibility of care, chronic condition, targeted care management, data infrastructure, and data sharing. And we talked about goals we set kind of an ideal state. We talked about measurement and requirements for each of those domains. And again, we'll be doing that again today for the last two. Next, we'll just remind you of kind of the in-person meeting where we rank ordered, again, those domains that we discussed. And just as a reminder of the top 5 where we landed, as you just heard. So it's that chronic condition, targeted care management, accessibility, HRN screening, community supports, data infrastructure and data sharing, and team-based care. And I did want to flag again that for the purposes of this conversation moving forward, that for behavioral health integration, we would want to include those under chronic condition and targeted care management, and also could fit under team-based care as well. So I just wanted to flag that and remind folks that that's how we're kind of proceeding. And the next thing I want to review is the key feedback from that October 26th committee discussion. Now, I will read through this because I think it's just helpful to reorient us to kind of our prior discussion and some of the high-level takeaways. So ideally, we'd be prescriptive about outcomes and flexible about how practices achieve those outcomes. When reliable outcome measures are available, we can be more flexible. When they are not, we may need to rely on priority process measures or requirements. The level of prescription flexibility we will likely vary by domain. There's a lot of variation amongst practices in terms of starting point. Consider how the program structure will give providers the flexibility and the time to build out targeted capabilities. The capabilities practices are developing should be applicable across payers. We should avoid creating Medicaid-specific processes and use existing processes and requirements when possible and where possible. We need to be careful not to create barriers to access by putting more restrictions on providers. We also need to consider what implementation supports practices will need. So again, just some of the high-level takeaways from that October 26th meeting. I think we'll go to the goals for today's meeting. And again, I know you've heard this a couple of times, but really we're looking for, as a starting place, a directional feedback from this committee on team-based care, on the topic of team-based care and health-related social needs screening and community supports. And how we'll proceed is the same thing as we did at the last meeting. We'll review kind of these proposed goals as well as ideal states that we've put together on the DSS side, and we'll be looking for your feedback on those. And then we're reviewing a non-comprehensive list of example measures and requirements we could use to hold practices accountable to achieve those goals, and also thinking about how to embed an equity strategy throughout. Then we'll discuss, are these the right goals? Are there other measures, requirements, or equity strategies that we should consider? I will just note that from our prior conversation, we did make adjustments to how we were planning on presenting some of this based on feedback we've already heard. For this domain as well, can we rely primarily on measures? Are there any requirements that are particularly important? So I think we'll go next and kind of just highlight one more really key thing, I think, before we jump in, just as another reminder about like, what are we hoping to get out of today's meeting? And it's, again, directional feedback on those things that I just highlighted. But it's important that what we are not doing as well is we're not deciding on a final set of measures or requirements. We'll need further discussion for that. We're not suggesting that we would use all of these measures or requirements. These are just a selection for discussion to help guide the conversation. And we acknowledge that we're going to have to be thoughtful about how many measures and requirements we include overall. And we're not finishing this work today. This is a discussion that's a starting point. Again, it's directional in nature. It will be informative for future conversations, including the next conversation on payment. So these are important. And also just highlight that this conversation is really focused on the expectations of primary care practices. We know that we need to have further conversation about the role DSS will be playing in developing infrastructure, payment, and incentive structures. So hopefully that just recalibrates us for where we are, the purpose of today's discussion, what we're hoping to get out of it, and where we're headed after this. So I think we can jump into, Mark, did you have a quick question? Go for it, or statement.
Yeah, I did. Thanks, Dr. Richards. I'm glad you commented on process because it's something that's been top of mind for our members, which is that there's these 2 meetings that are staked out for discussing program capabilities or requirements, if you will. You said it's really directional, but if you look at the time frame for completing this work, which I think is April or March, there's really not a time where we go from this 50,000 foot sort of sounding board to some ideas approach to a substantially more specific set of proposed or provisional program design elements. And so if this is just directional at this point, I'm wondering, what is the process? Because as you know, with maternal health, with the maternity bundle, there's a lot covered at a high level. And then when you, there are a whole lot of details that substantially impact one's assessment as to whether this is a program that's feasible and fair and all that stuff. So if you can just talk a little bit about how you see getting from these directional conversations to an actual complete program model that you launch would be great.
Yeah, Mark, I can take that one. Good question. The way that we're going to get there is that we are not going to meet the March timeline. We're a bit delayed, and I think that's okay. I think this process has been extremely useful, and we're listening and we're getting input from you all. It's taken a little bit longer than we expected, and that's okay. And so we are not looking to wrap up this process by March. We're looking realistically something more like May, June, July, and we're still thinking through a little bit the timeline. It'll depend a little bit on how today's session goes, but that's how we're going to square the circle. And that comment on delay is not a statement. I do think we've been quite successful so far. I feel like we're making good progress. It's just we want to make sure we really hear from you all before making decisions. So that's the plan.
Yeah, and just to comment that, just like you said, I think we've seen this as iterative and said try to set out a sketch timeframe, but realizing that the iterative nature means that we do need to make adjustments along the way, and that this initial design phase then needs to move into a more technical design phase where we do get into the details and the weeds on these specifics. So thanks, Guy, and appreciate the question, Mark.
Thanks to you both.
Can I ask a question? I can't find how I'm supposed to raise my hand again. It's on this big board here somewhere. That leads to a question of when you get to the specifics, are we going to have, I mean, that can get into really nitpicky sort of niche issues, and those can kind of gum up a whole committee meeting. And it also should be going out to a wider audience. Is there going to be something, some opportunity for public input on the much larger, more specific program once it's done? What's your process for getting to that?
Great question. I think, Guy, I'm happy to start just to say, we do anticipate continue to bring this forward also at MAPOC and bringing up discussions for feedback as well. There is a FQAC subcommittee where we also get feedback along the way as well. And I'll note that we're looking to take this to a member advisory council as well for additional feedback. So there will be additional touch points, and recognize there are difficult decisions and conversations that will need to be had, both in the near term as well as we get into more detailed discussions. So that there is kind of a broader engagement strategy that we've kind of laid out, and we'll continue to try to follow, and obviously make adjustments as needed.
I would just urge you to have a process that is in writing and transparent. Everybody can comment like the feds do on regs, where, if somebody has only a concern with one pharmacy issue or one other issue, it doesn't take up it doesn't overwhelm a committee's agenda. And all of us start checking our emails because we don't care about that. It's just I've found it to be a good way, and everybody gets to see it. And you get a lot more comment than the people who are on the committees.
Yeah, Ellen, that makes sense. And I hear that. And I think that seems reasonable. And I think the exact form of what we do, I think, will depend exactly on where this group and DSS lands on what we're doing, depending on how big a change we're proposing. I think that will influence, Ellen, and Mark, I think the form and also the length of time for that broader stakeholder input. So I hear what you're saying, makes sense. And let's revisit that once we're clear on the overall direction that we're hearing from this group, and we want to go. But I hear you both. It makes sense.
All right. Well, with that, I think we'll jump into the two topics for today's discussion. So team-based care. Again, we've made some draft goals. We took ideal state from, and we really tried again to lean on the OHS primary care primary care core team functions that have been outlined. And I think you'll see these here, but I think they try to get an ideal state for us. So the goal that we've outlined is enhanced team-based care with a focus on improving the care experience and providing care coordination driven by person-centered goals and needs. Ideal state care delivery is team-based with a practice team consisting of a range of clinicians and non-clinicians working with the patient, all with the defined responsibilities that are clear to the patient, and support the patient in the practice to the full extent of training and credentials. The practice team, number two, the practice team includes a qualified embedded clinical care management personnel to support patients in chronic conditions and disabilities and patients experiencing transitions of care, and embedded non-clinical care coordination personnel to connect all patients with community supports to address social risk factors and work with families and other caregivers. I'll pause here, see if there's any questions or thoughts on kind of this, on the kind of draft goal ideal state. Mark?
I was hoping not to be first, and so actually I'd like to defer to two of my hospital colleagues,
Sure.
and we'll stand down for the moment.
No problem. Ben? Ben, you're on mute.
Thanks. Yeah, I was having the same problems that Ellen was having. I couldn't remember how to make it work. And so my question here is about the word embedded, and whether that implies embedded in the actual practice. Sometimes, especially for smaller practices or practice that might be cost prohibitive, or it might not make sense if it's a small practice as part of a larger medical group with multiple locations. And so what some systems do, or some larger groups do, is have central care management resources that act as part of the team, but aren't actually embedded in the practice itself. And I wonder whether that's acceptable.
Yeah, I think these are not maybe as, you know, the word embedded, I think has some flexibility with interpretation to a degree. But I think it's a great point to raise of like, what does that mean for ideal state and purposes? And I don't know if David, if you wanted to weigh in, I think your hand was up.
Yeah, thanks. I was going to say almost the exact same thing that was just described, specifically in the context of small practices and the opportunities that advanced networks might be able to support those small practices while not necessarily having a full-time 1 FTE embedded care coordinator in that practice, because it may be not a good use of that individual's time.
Jim?
Thanks, Brett. So appreciate the embedded piece. To me is just being flexible in terms of sort of what you're trying to accomplish with it as opposed to not. The only question I had about this in the ideal state is, like you referenced, behavioral health was sort of needs to be embedded in the chronic care management there, and making maybe that needs to be more explicit here, that it's not just coordinating or giving potentially care management, but actually having to have resources to be able to get to and ensure that we have adequate behavioral health that manages those. It's so critical in terms of the chronic disease management goals that we have. Likewise, although down on the priority list was coordinating with specialty care, it is unrealistic unless you have a robust coordination with your specialist that you're going to ask primary care to manage chronic congestive heart failure, you go through the list of those that are really driving the poor outcomes. Specialty care is deeply involved in their management. And a coordinator, yes, should be able to do that, but I would be explicit that although the specialty care integration is down on the list, you're not getting to chronic care management, especially in this state, without robust accountability and integration with specialty care, who's going to drive a lot of the performance around that.
Jim, Mark, did you want to chime in?
So my comments have mostly been covered. I guess I would ask us to, my recommendations are aligned with those of Dr. Carden, which is to maybe to embellish or enhance what is covered in the goal because care experience and care coordination seem to be fairly don't seem to be as comprehensive a statement as to what could be achieved when you have community health workers, health coaches, dietitians, nutritionists, embedded pharmacists, and that sort of thing. That it's something else that I haven't been able to put my finger on exactly, but I think it's such an important element of where primary care is evolving to that it seems this kind of is to me seem too narrow, and we can offer some comments in writing offline, but thank you.
Thanks, Mark. Yeah, I think reasonable things that we'll know and definitely can take back to think about for next steps on this. Seeing no other hands, I think we can move on to kind of the specific examples for measures and requirements. So just as a reminder here, I'll walk you through the layout similar to last time. On the left-hand side, we're reviewing process measures and outcome measures. And you'll see in parentheses that of the specific measures, which program or organization might be using it or recommending it, and then who's the steward. And a steward is just who's responsible for updating and maintaining that measure over time. And I'll just also note that for as we think about process and outcome measures, process measures are really there to achieve the outcomes and not the other way around. I think that's a maybe easy way of helping kind of frame that and as we noted before, ideally, if we can focus on outcome measures, gives some flexibility how practices achieve those when they're good outcome measures that exist. In this case, we had some outcome measures, and we talked about hospitalizations, ED utilization as measures that we refined this based on comments from our last meeting where we added a few more measures to kind of try to be more comprehensive. And so you'll see the three here, one being the plan all-cause readmission. OHS has that on their aligned measure set. It is, again, stewarded by NCQA. We do, again, have avoidable ED use. PCMH Plus currently uses this. Our program 3M is the steward. Rhode Island Medicaid uses the NYU Johns Hopkins University algorithm. And there's also avoidable hospitalizations we alluded to last time. There's PCMH Plus 3M. There's also hospitalizations for potentially preventable complications that Medicare utilizes. That's an NCQA measure. And then also wanted to call out member experience related to team-based care. So there's two we wanted to know is PCMH CAP survey. OHS has that on the line measure set, CAPS is the steward. And in the last 6 months, often did your providers seem informed and up to date about the care you got from specialists? In the last 6 months, did someone from this provider's office ask you if there are things that make it hard for you to take care of your health? And then another survey, the PCPCM, which is the person-centered primary care measure that we're currently using in PCMH Plus, stewarded by ABFM and in the PCPCM. My practice coordinates the care I get from multiple places. The care I get in this practice is informed by knowledge of my community. And then for thinking about the equity strategy here, thinking about segmenting by race, ethnicity, language, as well as developmental disabilities, demographic information to help measure those disparities. Moving over to the right-hand side, example of potential requirements. Again, these would be program requirements. So one is, the first thing is just noting employing a care coordinator or other team-based staff roles. So one option that's used in PCMH Plus is employ a full-time care coordinator dedicated care coordination activities, assign care coordination activities to multiple staff within a practice, or contract with an external agency to work with practice to provide care coordination. Another one that's used in Mass Health is maintain at least one team-based staff role dedicated to the specific primary care site, i.e. CHW, peer, social worker, nurse care manager. And then another one option is integrating community health workers. PCMH Plus has expand role of CHWs and support full integration of interdisciplinary teams. Maine, one of their programs has offered community-based CHW services directly or through partnerships. And then Making Care Primary, the new Medicare program, has utilized CHW or equivalent professionals with shared lived experience to deliver services to higher need patients. And then a potential health equity strategy requirement would be cultural competency and/or ADA training for care team members. So what I see some hands up already, and just to remind everyone, we're moving on to kind of the conversation about, we already talked a little bit about those goals and ideal state, now talking about are there other measures, requirements, or equity strategies that we should consider? And I think maybe we'll keep the other slide up for a second, Olivia, just so folks can see as we're discussing, and I'll turn it to Jim, and then Ben, and then Ellen.
Thanks, Brad. A lot of what we have been moving down when we're trying to develop these team bases, really, it's solving the access problem, because that has been and is the biggest challenge we've got. And all of these great programs will be terrific, but unless people can get in and they're being seen and touched, you don't. Now, so it seems to me we need some sort of outcome around access, timely access to care. And I don't know, that's not easy to measure, and it's not exactly, and I don't know where to go. It may be a segment. Are people, as you said, following a process, they're being seen within several days of, what's your percentage of patients who are being seen within 7 days of a hospital transition or a post-acute transition or skilled nursing. But somehow I think that we need some sort of way to measure, timeliness to care, because I think it's the biggest challenge that we really have to face.
Yeah, thanks for that. Really agree. And just to connect the dots a little bit. So when we had our in-person meeting, we voted on some of the top priorities that we had on the what, and one of those was access to care. And last time's discussion, we focused on how we might try to quantify. James, I totally agree. It can often be really challenging to think about how to measure those, but I did think we had some good thinking last time on that issue, and I appreciate you bringing it up in this context. I think part of what you're saying, but correct me if I'm wrong, is if we add too many requirements on that may harm the access to care, that may be not what you were saying. I'm not sure. But anyway, I just wanted to recognize that we touched on some of those issues last time, and if you have additional thoughts, would love to hear them.
So my apologies, I couldn't make the last meeting.
Jim, sorry.
It's a little both of those, Guy. I just think that if we don't, you can only, like anything, you can't manage you can only manage what you can measure. And if we have implications that are suddenly increasing barriers to access to care, but we think we're doing great with the 5 patients we can see, we may look pretty good and are solving no real problems. And I just don't know. I agree with you. We're struggling with Hartford Healthcare. It's front and center for me every day. But it is something that just because we're struggling with it doesn't mean we've got to keep it front of mind.
Yeah, no, thank you. That's helpful. Thanks, Jim.
Yeah, and I think I'll just add that this did come up in the accessibility of care conversation, and note that there are programs that look for same-day access to care as a measure. Some of these are challenge. The question is, can we measure this effectively? And I know we talked a little bit even last time about data and accessibility more for practices, but on the DSS side, as we think about integrating with the Health Information Exchange and Connie, there may be opportunities for us to bring in data for measurement that we couldn't previously see or have access to that could actually aid in this moving forward. So we'll call that out as well. Let me turn it to Ben.
Thanks. Just first a question and then a comment. And so I just want to make sure that I'm understanding that the idea would be that the program would utilize what we see on the left-hand side, and there would be suggestions on how to get there on the right-hand side, not that there would be a mandate to do what we see on the right-hand side as part of the program. Is that right?
I think how we've outlined this is that ideally we would focus on outcomes. So on that left-hand side, when we feel like there are good outcome measures that we can both capture and hold providers accountable to, and then use requirements if we need to, or it's a really important part of the program. So nothing I would say is off the table, but generally, I think based on October 26th is lean towards real, high level outcome measures that we think drive towards what kind of the ideals that we're hoping to achieve, and then use limited requirements or other requirements when we are unable to, or we feel like it's really important to do that. So that's kind of outlined. So but they're still up for discussion. These are all, I would say, on the table as part of this, and we're looking for your feedback on, do these outcome measures make sense? Are there other process measures we didn't think about, or do these requirements make sense? I don't think we're not saying that we would want to use all of these requirements or all of these outcomes, because that would be, I would say, unwieldy if we try to use even just everything we have on the page right now.
Thank you for that. So I think what you have on the left-hand side are good outcome measures that should speak to the existence of team-based care. I think that as I think about it, the goal isn't for practices to have team-based care. The goal is for the practices to achieve what we're trying to get on the left-hand side, and team-based care is a way to get there. Asking practices to do what we see on the right-hand side without achieving what we're trying to achieve on the left-hand side doesn't help advance the Medicaid program. So I would not suggest having what we see on the right-hand side be a part of the ultimate outcome, except perhaps a suggestion for how we might achieve what we want to get to on the left-hand side. On the left-hand side, I think stuff around member experience makes a ton of sense. And I think that most practices probably are already measuring these things and have resources in place to manage and improve performance against these metrics. The stuff on the top, especially for smaller practices, and I am very mindful of independent practices. We want to make sure that they can succeed under Medicaid as well, so that all the burden isn't always falling to the health systems. Having the resources in place, like what we see on the right-hand side, to do what we see under hospitalization is very expensive and probably cost prohibitive for independent practices. And so when we think about the reimbursement model that we're ultimately going to put in place, we need to be mindful of the fact that there is capability building that will need to happen if practices are going to be able to move the dial under the top piece of outcomes.
Thanks, Ben. Ellen?
Yeah, I agree with Ben that, if it's a smaller practice and maybe they don't have a large Medicaid panel, this might drive them out of the program. I'm very worried about people driving out of the program, that this is just the last straw. They're just out. I think finding a way to support them in doing that, to share those resources, to figure out a way, but really what we care about is, and I love your outcome measures, the readmission rates, the avoidable hospitalizations, and avoidable ED. If they can do that without hiring a specific licensed person specifically for that, or having one FTE for it, if they can coordinate. The other thing I worry about is in some organizations, you put on a lot of requirements and it turns out that one person is designated to do them all, and they're not actually giving it the time that it should be given, and they're not specializing in it. You're just filling a box. So that would concern me as well, that it doesn't really happen. So we need to find a way to support those smaller practices in providing these kinds of roles if we really want everyone to be doing this. The questions, I think, are good. I think the one, I guess I'm concerned, the last one under PCPCM, the care I get in this practice is informed by knowledge of my community. I hope it's not actually written that way. And that's nice, but I'd like to know, are people actually getting care? Are they getting better? Are they feeling that they're getting, their food insecurity is down? They're on track to find a home. Actually, that would be an outcome. I do agree. I like the cultural competency and or ADA training. I wouldn't say ADA training because many providers see that as, oh God, I have to deal with the ADA, but just how can you be more welcoming to people with disabilities? And I think training for that would be really good. What else? and wondering, I feel actually, I've heard this from a lot of consumers and patients that they want to choose their own care managers, and that isn't always feasible. But sometimes it's not exactly the kind of connection that you need with a behavioral health provider, but it's almost like that. You need someone who you feel comfortable with, you feel confident that they're going to understand your needs, your social needs. This can be very sensitive stuff for people to be sharing. And finding a care coordinator and a good match is really important. So did people have a choice? And also to, I think it was Ben or maybe Jim's comment before that for some people, their specialist is actually who is coordinating their care, children with special healthcare needs, for instance, or people with very complex conditions. Is it make more sense for them to be able to choose a care coordinator there? Just a little more flexibility than there will be one person, and this is who you will go to.
Thanks, Alan. CJ?
Yes, thank you. Everything that was just said, and I want to add to that. Here's the problem with reports. When you're a bigger agency, your numbers will appear better. I find that this is very quantitatively based, not very qualitative. I mean, these things were said before, like we're not really thinking through the competitiveness for the smaller practices, and then also the quality of care when you put a certain level of burden, you know. So I want to pay attention to that. You know, the expectation should be that we don't just check the box. We actually do what we say we're going to do and don't recreate the problem. Thank you.
Thanks, CJ. Mark?
If you don't mind, I'd like to follow on Polly.
Sure, Polly, go for it.
Thanks, Mark. I'm just observing too that you know, the outcome measures that are listed here, if we do a great job at the care management, the health-related social needs, the team-based care, you know, those should also improve the readmissions, the avoidable ED, the avoidable hospitalizations. I think last time we also talked about, you know, under access, you know, annual wellness visits, preventative care. You know, to me, I also see that as team-based care. So potentially as an output of this, almost like a crosswalk, because I do think, you know, if we select, you know, great preventative measures, great outcome measures, like all of these things we're talking about, they're multifactorial, and, you know, they're going to amplify if we ensure that, you know, the capabilities are in place and the measurement is in place. I do think I like the member experience at the team-based care and the, you know, kind of practice level. And I think some of the capabilities around how the practice either has access to, you know, those care coordination resources, whether it's embedded or through a relationship, and being able to attest that they have access to those resources, I think are important as well.
Thanks, Polly. Hannah, and actually I saw Angela had made a comment, and Angela, I'll ask if you want to weigh in after Hannah, go ahead, and then Angela, I'll turn to you.
Great, thanks, Brad. Building on what some of our members have already said, got me thinking in the equity strategy piece. I would suggest cultural competency and ADA training. I don't think it's an and/or. Appreciate that it's additional training and effort and time on the part of the provider. But I don't think that we should be looking at one and not the other as a comparison for both. So I'd just like to note that.
Thanks, Hannah. Angela?
Hi, good morning. I just wanted to share, and I dropped in the chat, a phenomenon that I don't know if any other communities are experiencing this, but what we're finding is that when people are actually sick or not feeling well, a lot of them are getting the go to urgent care, like, and it takes months to actually get an appointment with your own primary care physician. Sometimes it can be as long as 3 to 6 months. And so having insurance, whether it be Medicaid a qualified health plan, you know, it's not helpful if you can't see your doctor, particularly when you're not feeling well. So my question is, are we measuring that? Those communities like North Hartford that doesn't have urgent care facilities, the alternative is the emergency room. So why do we see an increase level of activity in the emergent utilization of the emergency room? Because our community doesn't have urgent care facilities, which doctors are saying go there because we can't get you an appointment. If we reward primary care physicians for shortening the time it takes to get an appointment, that could help divert traffic from the ER. However, is anybody even measuring that length of time that it takes to get an appointment? And if so, where is that data? If we're going to actually create solutions, what we're going to call solutions, that's something that has to be measured. And if we don't measure it, it's not going to improve. If we don't divert from the ER, the costs are going to continue to rise. So it's like the catch-22, what comes first?
Thanks, Angela. And I definitely appreciate that. And I think you're right that like these are challenges that, you know, that the focus on utilization of emergency room and especially avoidable ED and hospitalization. I think we're challenged, I'll just say on the data side of capturing one of the things you said is like, do we know that if someone calls, they can get same day access? That is something that we might be challenged to have that data for. But what we could measure are those other outcome measures that hopefully would incentivize the primary care providers to care a lot about making access. And whether it's same day access with the PCP or it's a team member, I'll just say as a primary care provider myself, one of the things that I did in a practice before is we created the internal urgent care center for our own patients only, so that someone calls up, we can get them in usually same day, sometimes within an hour or so, or we'll have someone try to triage them. And, you know, I think there's a lot of solutions depending on the practice. But what we want is people to be able to have access. And maybe sometimes that might just be a televisit, or maybe it's just a phone call with someone that knows the member. And so I think you're right. We need to figure out how do we incentivize that. So just saying we may just have to be creative about what we're holding providers accountable to. And some of the data pieces, maybe something either we have to build, which could be very costly, or things that we can measure in alternative ways. But I appreciate the importance that you raise. Mark?
Thanks, Dr. Richards. So I had a comment about measures and methods and team-based care. So in talking with our members, a couple of things were important for them around measures. One is that the technical specifications for the measures be transparent, that is non-proprietary. So there was some support for an avoidable ED use measure, but not a measure where those who are subject to the measure who basically are not privy to the calculation. That was a very strong point of emphasis, and I believe the 3M method doesn't allow for that. The other is that concerns about reliability. So the CAHPS survey measures have shown up on a number of elements at this point, but especially when you get down to smaller practices, but even without smaller practices, the question is, are we getting response rates that are reliable and accordingly would be appropriate, fair and appropriate for use in this purpose? And I don't have an answer to that. You know better about the response rates, but that's an important consideration. The third is that there are things like Ellen mentioned, housing outcomes, which are, I think we all believe are important, and certainly the research would suggest that, but may not be appropriate to hold primary care accountable, and that might require more of a systems intervention. And I personally believe it's important for the Medicaid program, but probably not realistic for primary care offices. And then finally, a general expression of support for aligning with the aligned measures set recommendations that OHS curates, that the point there is to reduce burden and to align as much as possible, and we would support that. Finally, with regard to teams and Ben, I hope you're listening, because I think we have the dilemma here is whether to specify the team components that are the team members that should be among those who are included. So when I looked at that team-based measure list, I thought, well, where's behavioral health? Where are nutritionists, health coaches, navigators, or even integrated pharmacists? Dr. Carden, I know that at Hartford Healthcare, you've done a lot of innovation around integrating, medication therapy management through pharmacists. And so on the one hand, there is this, well, don't burden us with a whole lot of requirements around process and what we build. At the same time, I recognize that as with the pricing that with doulas and maternity bundle, you have to put a dollar amount on that if you expect people to hire or retain doulas. And so the thing here is that there needs to be enough of a concept about what will come, what folks are going to be building out to in the way of team, and then aligning that with the new resources that you've committed to bring to this process. And so I would just say that I'm very mindful in this conversation, both about thinking more comprehensively about where team-based care has evolved in the past 10 years, and also ensuring that we don't forget about the importance of matching that with the level of resources necessary for success. Thanks.
Thanks, Mark. Yeah, and I'll just quickly say, I think we realize this process, we can't do everything for everyone. I think that's as part of this, is that we will have to be parsimonious in the recommendations, and we're getting all of your input and thinking about what we realistically will be able to do in trying to focus in on those things and hopefully do the things that are most important well. And so we'll have to continue to return to that about what is team-based care, who are those team members, and then obviously we haven't secured resources on the DSS side or the executive side to build that out, and what will we be able to get as part of what an ideal state might look like, and those will have to be ongoing conversations as we move through this process. Sorry, go ahead, Mark.
So Dr. Richards, I wonder if you've used surveys to help prioritize or to surface the things that are most interest to members of the team. I wonder if it makes sense to prepare for that future conversation about team-based care, to ask the committee members through a written survey to share out what they believe are most important in terms of team-based care members, just as one point of reference to inform the next conversation, just a suggestion.
Thanks, Mark. We'll take that back. CJ?
Yes, I just want to second what Angela shared there, because that's really important. We have folks who are overutilizing urgent cares, and that skews the data big time. Because what's the point of asking for data that's not real, right? And then we have the problem with the emergency rooms. All of this is relative to access, which also in turn affects your quality of care and your confidence in even getting care. So I hope that is really taken into consideration. Thank you.
Thanks, CJ, for emphasizing that. I think at this point, seeing no other hands, we can maybe move Olivia to that next slide. And just to say, I think we touched on the last question a bit. Just curious if anyone wants to say anything else on that for this domain. Do you think we can rely primarily on measures? Are there important requirements that are particularly important here? And I think Ben's touched on it, and folks have touched on this already. I just want to allow for any more input on this specific question before we move on. Seeing none, I think we'll head on to our health-related social needs topic, and similar format again. So again, we drafted a goal, and ideal state. Ideal state again is taken from the OHS primary care core features here. And the goal is acknowledge the role that social terms of health play in member health and well-being, and better identify and address health-related social needs. Ideal state, the practice team identifies social risk factors affecting its patients and is knowledgeable about community resources that can address social needs. I'm going to pause here, see if there's any input, reaction to either of these. Hannah, please jump in.
Great, thanks, Brad. I think we were just had discussions about this during OHS when we were going over these measures. One of the biggest kind of items that we came back from was that the practice team is identifying the social risk factors, but it's not necessarily trickling down to the patient. There's no actual connection between them being responsible in some way that the patient gets access to the resources or knows about the resources. So just wanted to point that out and see if people had suggestions there.
Thanks, Hannah. Yeah, I appreciate that point. Potentially connecting people or need to connect people to those resources. Ellen, please.
I think Hannah gets to a really good point that was also brought up, I think, by Mark. It's like, yes, we want to do this. And I guess this is going to be my comment on screen and refer, is that it's just another person who you're, sharing your needs with. Is it ever get to something useful? Because that's, referring to a waiting list doesn't really help anybody. And it's a reason why in the evidence, looking at the evidence in the literature, there are very low engagement rates with these. People often say, no, thanks, I don't need help with that, because they know they're just going to get the same list of resources that they already know about. They're already on the list. They're already doing what they can. And I do think there needs to be something to figure out whether this is just, a sort of paper shuffling and whether something actually comes of it. I do think it's not fair, though, to hold hospitals and practices, even how big health systems, accountable for whether people can get a home. That's a big lift, and they can't do it alone. I think that gets to a major problem that comes up when you want to connect primary care to community supports. Connection is fine, but once you start talking about accountability, it gets very complicated. And it's a tension of figuring out what makes sense in terms of the money and providers' time to devote to this versus the what bang are we getting for the buck.
Thanks, Ellen. And I'll just, as you probably recall from all of your input on kind of where we should land on these various domains that we had previously on the health-related social needs, we talked about kind of like what's the spectrum of options. And I think, really folks landed in the middle on screening and referral as opposed to being accountable. And so that's how we've approached kind of this conversation, but appreciate that, Ellen. Mark, please.
So I think, Dr. Richards, you may have just answered the question that I had. So when you did the survey and you asked us about the sort of 3 levels of HRSN expectation, the lightest touch, I don't remember, the middle I thought being identifying and facilitating access to services, and the other is providing HRSN services. This seemed more like the first bucket than the second bucket. So what was conspicuous here is I was thinking that you would screen patients for social factors that could affect their patient outcomes, that you would maintain access to a directory of community resources that addresses the needs that are most often encountered, and that you would facilitate an electronic referral or a referral that enables the documentation of a closed loop. To get to Ellen's point, there's actually technology that not only allows determination of a closed loop, but that they didn't get to a waiting list, right? That they got to something other than a waiting list. So that's where the state of the art has evolved to with regard to the platforms that are out there. And I'm wondering why it was more of a thin expectation for the ideal state, if you will. If that's about the fact that it's got to be feasible for smaller practices, or sort of what you're thinking is.
I think, Mark, in this case, we were trying to, as you, I think, alluded to what the aligned measure set, is also having some aligned core functions. And so And I think, Hannah, you jumped right in early on and said, hey, this is one of the limitations of how this is framed in the from the OHS list. And this may be one where we actually move away and say, we're going to adjust this ideal state because it just makes sense to. And again, I think feedback is very helpful, and appreciate, Mark, what you said, and Ellen, what you've said so far, and Hannah, your comment as well. So Polly, let me turn it to you if that's okay.
So if I could just, Dr. Richards, just make one other comment as a bridge to the discussion in January about payment. So one of the concerns I have is that the interest in including small practices with limited resources and capabilities might set up a lowest common denominator that is the basis for establishing expectations. And if you look at places like Making Care Primary, the federal program, they have tracks. That was also true in the Accountable Communities for Health initiative of CMMI, is that they look at sort of the level of readiness to take on a certain level of capability. And so it seems to me that I guess the question is whether you have given thought to and would consider a tracked program, so that the medical groups that are, some of the FQHCs and some of the medical groups that are affiliated with our systems who have advanced a great deal on team-based care and HRSN screening, that there might be a level of reimbursement and commensurate expectations that might be different than your average independent practice. And I'm not looking for like an answer, but just as to whether that's even on the radar for the January conversation.
Yeah, I think it's definitely on the table as an option if you've seen other states have approached, like you said, tracks in that way. So it's, I think, part of a conversation that we'll need to have. I'm not sure it will come up necessarily in January, depending on the size and scope of where we are able to have, but it definitely is something that will need to be discussed. So appreciate that, Mark. Polly?
Thanks, Brad. I guess, so, I know one of the discussions around, screening for health-related social needs often gets linked with ensuring then that there's a way to intervene or provide support for the patient and connect them with community resources. And, we kind of get stuck in the chicken and the egg. Are there community resources? Will they be, sufficient to meet the patient's needs? I think what sometimes is missing in in that conversation for me is going back to those outcomes too. And, do we believe that doing the screening is also raising providers' awareness about some of the challenges that their patients may be facing? How might they adjust their thoughts around the care plan for the patient education? If they're, diabetic and struggling with food insecurity, for example. So, I do think the connection to community resources and building those programs are important, but, would also, reflect that health-related social needs are also thinking holistically about the patient and developing, kind of care plan strategies that can also be mindful of what those obstacles might be for the patient.
Thanks, Polly. Yeah, and I'll just note, I think some of the, and I think comes back to what maybe Jim and Mark, others, Ellen, I think you may have said, is that some of these pieces will ultimately fit together in some ways, because, if we're thinking about acknowledging the challenges, Mark, that you brought up about measuring member satisfaction and experience, especially with small ends, but these pieces can start to tie together to a degree. Like, do people feel heard and listened to by their teams that are taking care of them, and are they getting their needs met? And if you're a provider, I mean, I've run into this in primary care myself, where you don't realize someone doesn't have access to refrigeration for a specific medication, and you prescribe something that just doesn't make sense because you haven't actually been thoughtful or asked those questions. It's hard to actually meet people's needs, and sometimes we're not even addressing the real need underlying it, because gosh, yeah, maybe that medication's nice, but what I'm most worried about is X, Y, or Z, and I wasn't asked that. And so I think we'll try to bring some of these pieces together as we return about how do they fit, how might they overlap, and how do we build off of that so that we don't build something that's so burdensome to providers that it's not doable, but also that we are driving towards a common goal of, a common vision of what are the priorities for this program. So Ellen, let me turn it over to you.
Yeah, I guess I have several thoughts. One is I I understand Mark's, especially from a provider perspective, the idea of tracks. However, that concerns me, I guess, because every Medicaid member should be getting that that help if they need it. So I would like to find a way where, ideally, in my head, this was my thought, that providers could be one of many people they see, teachers, clergy, and they say, are you having trouble meeting your basic needs? Are there things we could help with? Do you need help with basic needs that affects your health? And if the answer is yes, that could be the one screen, period. And if the answer is yes, they go to some place. It could be a network, or it could be a centralized system that is appropriate for that, instead of 1,000 different choices, like a 211 database to choose from. And then it goes into a public health system. The other issue is the money. I worry about the money. One of the pieces that I read, one of the literature, was that the screen and refer costs about $5 per member per month, is according to their modeling. And so I did a back of the envelope, and Guy, don't judge me here. But that's $60 million a year in this program, which is 30, a little less, maybe 25 million in state funds. And looking at the ROI for public health initiatives, we could get, even though we get a 50% match on Medicaid money, but if we do it through public health, we could possibly get a much bigger return on that. So every dollar you spend on something is an opportunity lost. So I really think we should be thinking about the burden on providers and the accountability for providers. And frankly, that's not their job to get people housing, and putting it into a place where that is somebody's job, just making the connection and then letting it be. That's, I guess. And I don't know if everyone has looked at, like, California is having some problems with their very ambitious plan to do this. So I think we're looking at, this is really hard stuff, and maybe we should do this slowly and carefully, and make sure that the resources are going toward filling the needs rather than identifying needs and then not having resources to actually fill them.
Thanks, Ellen. CJ, and I think Jim, I saw your hand up, maybe you put it down, but CJ, go ahead, and then Jim, if you want to weigh in after that.
Yeah, I'm worried that we're putting up an expectation. I mean, all right, COVID should have taught us, and I'm saying this particularly to the providers, COVID brought it out. People are going to share their need. Well, I didn't make the appointment because my car broke down and XYZ, right? However, DSS is DSS, a doctor is a doctor. You can only do so much with what you have. And I get wanting to integrate the services, but at some point we have to recognize, where does it make sense? And where do we need to gently say, maybe no? You know what I mean? And this was said before, right? We're doing all these reports for expected outcomes, but in actuality, some of this is not fully feasible. And again, let's keep in mind the quality of care. Let's not set ourselves up for failure here. I know we want to help people, and I know we want to do it together, but let's be realistic. Is it going to be perfect? No, but let's be open to the fact that when we break things, we could fix it and actually fix it. But as Ellen pointed out, let's take our time too, because this is not something that we should rush and also put too much processes within processes for, because that's why we're here. Thank you.
Thanks, CJ. Jim, did you want anything?
Yeah, I think it's mostly been said, but just in my head, what it is there's, I think Polly and Mark and everybody sort of said it. One, I get the idea of between both screen and require referral. I think that's a reasonable responsibility, but that then means the team-based approach to care here starts to get outside the delivery system. And there's going to be accountability that when you refer, that there's going to be programs and accountability that they will deliver, because the fastest way to undermine this thing is I refer, I'm doing my box, I'm sending a referral, and they're going to somebody's inbox that I don't know anything about, and I don't know how good they are or anything else. So we just got to think of the downstream implications to make sure we're building that. I think it's the right thing to do, but it does get outside the scope of this, of sort of our domain here is what we control.
Thanks, Jim. Yeah, I think important follow-up conversations that we'll probably need to have about, again, where we kind of landed on this middle ground, like basically the three options again were like status quo, we don't ask providers to do anything else. Middle ground was a screening and referral, and then last was addressing limited health-related social needs. And really the overwhelming feedback from all of you is kind of the middle ground. What exactly that looks like, I think, is important for us to think about, including what are the costs of that? What are the benefits? What are the downsides? And I think that's helpful and to think through, and appreciate a lot of the thoughtful comments. And I think we can go to the next slide.
Right, I just say one quick
Yeah,
thing.
please, Steve, go ahead.
This is connecting, I think, comments from various folks, including CJ, Ellen, Jim, and others. In my mind, at least, and feedback very welcome. We want to think about the costs and benefits, and the benefits of the screening and referral depend critically on where you're referring the person to, and does that organization have the capability to do something with that, as opposed to just having it appear on a list. And just as an example, there's a separate discussion about Medicaid's role in health-related social needs. New states, some states have gotten more than 15 waivers to cover, for example, food and housing. That's an ongoing policy debate here in Connecticut. I'm just saying, all else equal in my mind, depending on where that conversation goes, that would, I think, impact the relative returns to that screening. In particular, if we had a food program statewide that was funded through Medicaid for, a targeted population, that boosts the returns to screening. If we don't, then the returns are lower than they otherwise would be. So in my mind, where we go on this one a little bit is dependent on those other conversations. And CJ, I think that relates to your comment about going slowly, or maybe my words, not yours, but to thinking about how this policy interacts with other things that we're doing or not doing in Medicaid.
Yes, because here's the thing, this is a moving target. This is a moving target for the doctor who created a business because he was inspired by maybe father, purpose, whatever it is, and he just wanted to do medicine. Opens a practice. Now he's part of this. Now he has to employ someone, train someone, manage that. It's a lot going on mutually, right? And I genuinely appreciate the referral network. However, it will be Darwinism for the survival of the fittest. So let's leave that open for consideration and take our time with this, because it's been a tough road after COVID, especially on DSS. That's all I'm saying. Like, let's not make it seem like we're just palming it off over here. Let's give it the space. So thank you for that, Guy.
Thanks, CJ. Mark?
Alziz, if you're eager to move on, I wanted to comment on two things. What Guy is saying about what other states do to provide Medicaid coverage for food solutions like food as medicine or housing transition assistance is critically important, and could help address the capacity constraints that Dr. Cardin's referring to. But it's still a sick care model, and I want to heartily concur with Ellen. Ellen, I don't often heartily concur with you, but I've noticed in your op-eds, you've increasingly drawn a line to public health versus healthcare solutions. And I do believe that with a little creativity, there's a way to use Medicaid resources to address the needs that are creating the pipeline of issues that patients present with every day. And that I think this aligns with things that Angela Harris and Stephanie Clark have said as well, is that there are solutions in the community, and there are ways to address the SDOH side of things, the structural determinants, as an adjunct to the solutions Guy, you and DSS are exploring with Representative Gilchrist and others around making it possible to cover patient care related, health related social needs under Medicaid. So couldn't resist adding that comments. Thank you.
Thanks, Mark. I think we can jump into talking a little bit of measurements and requirements under this. We've had a great conversation, I think, on this already. And I'll just jump right in and note that, again, on the left, we have our measures. We have some process measures. The process measure that several states are doing is the social terms of health screening. Many programs are requiring that, including in Mass Health, Rhode Island Medicaid, several CMS programs, and it's typically been defined and stewarded by those states and programs. Some outcome measures that we thought may also be applicable, you'll see are the exact same ones from the last, where we talk about readmissions, avoidable ED use, avoidable hospitalizations, knowing that social drivers of health-related social needs very much can be drivers of the utilization pattern. And then thinking about, again, the similar equity strategy of kind of segmenting by race, ethnicity, language, and developmental disability to help identify areas of more need and improvement. And then on the right-hand side, the example requirements is using SUH data to implement interventions and prioritize those needed community resources. You'll see PCMH has a little bit of this where it's monitoring social determinants of health at the population level and implement care interventions based on the data. Use information in the population served to identify and prioritize needed community resources, food bank support groups. And another big bucket is maintain an inventory of community supports and refer, coordinate, or partner with social service providers. So the first one there is maintain that inventory service and supports. Mass Health is using that, CPC Plus, Primary Care First. Other ones are develop and implement referral and coordination workflows. And the next one is partner with social service providers. The last one is integrate community health workers. That also came up in our team-based care. And you may recall we already mentioned specific programming examples and how that could work. And again, kind of report on identified needs here based off of kind of BREL and IDD demographic information. And I know we've already kind of had some discussion about where this might fall, but would welcome additional commentary about, where we might want to land in terms of these process outcome and requirements. So Ellen, let me turn it over to you.
Yeah, I did see that the outcome measures were the same as for the team-based care, and I'm not sure that's really the best fit. You can affect, I'm not a clinician, but you can affect things like readmissions, ED, and avoidable hospitalization in ED with improved access to primary care and with team-based care, because you can actually make differences in people's healthcare. It takes a long time when you're trying to change social determinants to affect any of those things. Even with Housing First, that's first. There's still a lot of other issues that don't necessarily get addressed. It takes a long time to get to there. That list would scare me if I was a primary care provider, to think I'm going to screen and refer people, and then I'm going to be responsible for all these things related just because of their getting to their social needs. I think that's too far. There was a consultant who wanted providers to be responsible for reading levels of third graders. I mean, it gets a little out of control at a point, and I don't think it's fair. The other, I rarely do this, but I might look at more at process issues, things in surveys. Did somebody ask you if you needed it? Do you feel that you could share that here? Where else would you share it? There may be questions like that could be more useful. Also, reporting on identified needs by REL and IDD, that's great, but reports are just reports. They end up going in somebody's circular file. That doesn't feel like it's really getting to actually addressing those goals.
Thanks, Ellen. I'll just add, I think in terms of this outcome measure, and as we're trying to think about what outcomes might be driven that we could measure by having various health-related social needs, knowing that, not everyone that has housing insecurity is going to the emergency department because of that, but it can be influenced by some of those things. And so as we think about, if I'm a provider trying to address either readmissions or potentially avoidable ED visits, and I'm thinking broadly about causes, I would need to be thinking about health-related social needs and how those might be, understanding there may be limited interventions that providers can have an effect on, but there are things that, if you have a good care coordinator or a community health worker, may be able to help people navigate challenges within the larger social service system. So just acknowledging the impact, knowing that it's not a perfect outcome measure for did this person get housing when they needed it, but something that may be related to it. Ellen, feel free to, if you want to jump in.
Yeah, I do. I just think that that's a lot to ask. And I think we can get at it by asking them if they did the things that you just listed. Are they identifying needs? Are they maybe reporting on those needs to the state about, we need more housing, for instance, things that are within their control to do. I just think looking at these, and I mean, generally I'm a big fan of outcome measures, but that's more around medical care, not so much with social SDOHs. And I think we hold public health accountable for those kinds of outcomes. And I think that's more appropriate. Is my just in this particular project, I think that list will scared me, and I'm not a provider.
Thanks, CJ.
Yeah, to go to the comment in the chat, I do agree with what Paulie's saying there. I think this is an area where we want to focus. All right, so a doctor's goal is medicine. DSS's goal is social needs. I get it, wanting to link it, but we have to be realistic here, right? Because this looks more like a DSS intake than it looks like a questionnaire that I'm happen to be doing while I'm in front of my doctor. And think about the primary care person. Like, here I am having to be a clinician on the fly. So I hope that the calls to review this and really consider it holistically. I understand, trust me, I get it, especially for those facing housing insecurity. This might be the closest they'll get to a doctor, but then we also talked about appointment time. So I can't get an appointment to do the quiz, and now I go to the urgent care that doesn't do it. Did we solve the problem? Thank you.
And Mehul, did you want to jump in?
Yeah, thanks, Brad, and thanks for the themes in the last few comments. A couple of things. One, I think I know that there's a tendency to kind of view SDOH and HRSN in kind of similar terms, but I think the distinction is important because I think what HRSN points to is more of an immediately solvable non-clinical problem, whereas the broader term SDOH refers to these broader issues, which I think it's natural to think that it's going to take a lot of time and kind of structural changes to solve, such as housing supply. In the SIM days, we did a deep dive into what primary care practice could potentially do around asthma. And I think there's good evidence to suggest that, linking, in this case, children with frequent asthma exacerbations to home-based visits where there could be immediate education and action around removing triggers could have an impact on some of the outcomes that we're discussing. We'll see at least a contributory impact on avoidable ED. So I don't think that we need to, I think there's probably some fast tracks here around health-related social needs where I think we might consider focusing on, and asthma is one example, but there's probably a few others as well, where we're not sort of overwhelmed by the sense like, the entire neighborhood or community or society has to change before we can address these. I think there's a couple of fast tracks we could identify here. Thanks.
Thanks, Mehul. Polly, and then Robin.
Yeah, and again, I mean, I think there's immense commitment to this work from this group and, passion around, putting programs in place. I think, the other aspect that I, just having seen the work of our, screening and referral and our community health workers, they are able to connect patients with resources that the patients didn't even know that they were qualified for. They've gotten utilities assistance, they've gotten people into SNAP and WIC. So I think, it can seem overwhelming, or we may presume that folks know what resources are available, but I wouldn't, I do think, we should, again, start the work thinking about how we can build more of those connections, but that there are already really good programs in place for which individuals are qualified for and may not know how to access. And, making those connections to existing resources, I do think is worthwhile, and thinking about what supports the providers need to be able to put those in place.
Thanks, Polly. Robin?
Yes, I think what we're talking about in terms of providers, like Cece even said, that they're focusing on really giving, making sure that we have more access to their medical care, and then looking at some of the social determinants of health. I guess my concern with some of this in terms of who would be asking the questions, in terms of if it's not because just the referral was given to the CHW. So if I went to the doctor also, or I went to urgent care, you started asking me all of these questions, I would really be concerned about what you're going to do with it. And then, would also be concerned whether or not, you would be calling DCF. Next thing I know, a DCF worker is showing up, at my door. So I do think we need to be careful in terms of, even in the doctor's office, making sure that, we're clear with where the information will go to, who actually asked the questions. And then, making sure that it is the CHWs really, I don't see how, also it'll be interesting if, if they're focusing on, the medical piece of it, but then, maybe they're not so savvy about social determinants of health. And I would be concerned about giving you my information, especially if I'm concerned about whether or not you're going to report that I don't have adequate housing, that I am in a place where, the environmental is not great. And so it's contributing to my child's asthma, also. So I don't know if some of these things, they may have been discussed before, but that would be some of my things that I would be concerned about also. And I think that, just based on, disparities and, racism and things that people encounter, I wouldn't want to give this information all of a sudden a DCF worker shows up.
Robin, it's Guy. First of all, thank you for that. Thank you for that comment. That is really thoughtful and really consistent with feedback that I've heard from some of our members as well. I guess a question back to you. Should I read your comment? I can read your comment at least two ways. Maybe there are others. One way would be, hey, Guy, if we move forward with something like this, let's be really careful and get a lot of good stakeholdering with our members and others or advocates on how we do it. Another way of reading your comment is, Guy, I have concerns about this entirely. I mean, it's sort of like the foundations are really challenging. Can you just say a little bit more? Are you in either of those camps or neither? Just could you elaborate a little bit more, Robin, if you would?
Yeah, I would. I think both camps I would be, yeah, I think both I would be concerned about. And the reason why I said that, even today, I heard from a person from my congregation whose child was at school and had a toothache, and went to the school nurse and reported that she had a toothache. And so the social worker talked to the school nurse and said the child. So then they asked the child, when was the last time she had been to the dentist? And so she said, well, she didn't remember, but her mother probably remember. Anyway, to make a long story short, DCF was called and a report was done for medical neglect. Now, the mom had actually taken her to have her teeth, cleaned for her regular cleaning this year. But nobody called the mom, nobody talked with her. So that's what I'm saying about, sometimes when you're giving out, people are giving out information, just to be reassured, where is this information going to go? Is it going to cause me more problems than being helpful?
Thank you. Really helpful.
Just looking at the time, we have about 5 minutes. I want to make sure we end in a timely manner. CJ, Mark, I see your hands up, and then we'll move to wrap us up. So let me turn it to you, CJ.
Yes, just to add to what was just said. So also in the case of those who are not naturalized citizens, that would be a fair, right? Because these folks are mandated reporters. So as described, if I go in there or you question my child and they don't know, why would a child know when their last doctor's appointment is? They wouldn't know. It's not a safe environment. So I want you all to think about that, because who is asking the questions? their level of cultural competency, humility, right? And the ability to just really positively interact with who they're talking to is very, very important. And I get that we want to integrate service, but let's not lose quality of care in that. Thank you.
Mark?
Thanks, Dr. Richards. I had a question about what the intent is with the requirement partner with social service providers. I'm familiar with a lot of what we're doing now in terms of creating connections to support closed loop referral, but the partnering is vague, and I don't know if there's more that CPC Plus or Making Care Primary say about what partnership means.
Olivia, do you have any more you can add on to that?
Yeah, I think it looks different in different programs. I can speak actually to the Rhode Island Medicaid example in a little more detail. So in that instance, the requirement was around funds flow. So organizations were required to identify at least one social service provider, right, associated with a sort of priority need, and then to pass through 10% of their funding. I don't know that the CPC Plus and Making Care Primary examples require reimbursement as much as they do, you know, a sort of more integrated referral relationship. So could follow up on that point, but yeah, I think some different formulations of that across programs.
Thanks. It's helpful. We also implemented a program under SIM that was about contracting with specific providers around, like putting on air as providers around joint contracts to hold them accountable for achieving certain value-based outcomes, like asthma control, for example. So I didn't know whether you had something like that in mind, but that was a piloted program for a couple of years. And so.
Thanks. Just for timing purposes, Ellen, I know you put your hand up. If you want to put in the chat or send a note, I just want to make sure we wrap on time and just want to say next steps. But definitely appreciate the commentary. And I know there's a lot of important discussion. Like I said, we will need to bring this back up in the future as we try to get more into specifics. And I think a lot of the conversation today is really helpful. So I just want to frame that we're really headed towards, you know, today is kind of like having to define success a bit and how should this be measured. And I think, again, we've gotten some directional feedback. This is not, again, we got a little bit into some of the weeds here, but we are going to have to revisit that in the future as we get to technical design components. And then we are going to be moving to think about how primary care is paid, incentivized for doing things that improve member health and well-being, and really trying to align with the conversations that we've been having along the way and how we're and where we're going. So I think that is going to be the next conversation, and we will do similar process that we'll try to make sure we have the meetings material about 7 days ahead, time to read and prepare. We'll get location and details similar to the October meeting to you. And again, as kind of asked earlier in terms of process, I think on the next slide, we'll probably skip it just for timing purposes, Olivia, but just to say, we know this is an iterative process. We know timing will take, it will take some time to get us there. And that's okay. We anticipate at this point that we will recalibrate based on where these conversations take us, as Guy said. So I just want to thank all of you for the time and your input and your willingness to have discussions about how do we think about this? How do we think about what are the various considerations and the various and unique perspectives that all of you bring? Really, really appreciate that. Guy, anything else as we wrap?
No, I totally agree. Thank you. And I just want to put a plug in. I do think the meeting on the 18th is a particularly important one. I think the last several meetings we've had been really helpful at setting the stage, thinking about what we want to focus on, how we would measure it. And just as I felt our last in-person meeting was really helpful for bringing the group together and making some progress, I'm hoping and expecting that the meeting on the 18th will be. So we'll hope as many of you can make it as possible. And if we don't connect before then, happy holidays.
Yes. Thanks, everyone. Appreciate it. Happy holidays.